So for upper tract disease in general, there's not much great guidelines for level 1 data for adjuvant therapy, obviously from the PAL trial, and a few phase 2 trials in regard to neoadjuvant therapy. For N1 disease, for node-positive disease, there's even sort of less in general. There's been a few studies, retrospective, that have looked at neoadjuvant therapies, and a lot of this is just corroborated, extrapolated from MIBC and muscle-invasive trials. So classically, again, level 1 data shows that for just in general upper tract disease, you can do adjuvant therapy. That's the only level 1 data out there currently for treatment of upper tract disease. Upper tract is just so unique. It's people extrapolate it from muscle-invasive disease, but it's also its own unique type of subset of disease. For sort of, I think what it sort of shows our data is that this neoadjuvant treatment might sort of help these patients. It still shows that in overall what we also gathered is surgical consolidation might be a very beneficial aspect of treatment, whether they get chemotherapy before or after. It's hard to tell. Cancer database studies aren't perfect. It doesn't always sort of lay out the whole picture. We also do a very bad job with clinical staging, with imaging modalities. It's when biopsy is taking tiny biopsies, trying to get whether it's muscle-invasive disease, whether it's node-positive disease with imaging. It's not perfect. I think there is a play with surgical consolidation and sort of the mothership theory with prostate cancer, of getting rid of the mothership that can help with these outcomes. It's hard with chemotherapy only because, again, it's database study. Were these individuals that started off as neoadjuvant candidates, then to a point, it was like they're probably not ready for surgery or not good for surgery. Let's continue them on the chemotherapy arm, per se. So that's sort of one of the limitations of these studies with looking at database retrospective review, is you can't really tell who fell off. I think it's pretty exciting. Again, a lot of our studies have been sort of extrapolated from the bladder cancer space. So things with dose-dense MVAC, adjuvant IO, immunotherapy, all those things can be considered to be implemented. So it'd be pretty exciting to see just sort of how we approach that with immunotherapy getting bigger in the forefront, as well as like circulating DNA, urine-free DNA, trying to look at those and seeing if that can help sort of guided therapy of upper tract disease. I think this just shows that there still needs to be a lot done. It seems to show that surgery is a possibility for this node locally advanced disease. Currently, the only guidelines with the EAU is to suggest upfront chemotherapy for node-positive locally advanced disease, then can consider surgery after systemic therapy. So it's not really hard guideline. The NCCN guidelines also for upper tract disease is 2 pages. So there still needs to be a lot of study. And I think, again, with immunotherapy, circulating DNA, targeted imaging, I think it's getting up to a forefront of where we can really expand of what we can offer these patients.